All right. Welcome, everyone. Good to see you. This is the 24th meeting of the Crisis Response Improvement Strategy Committee, and I am Jamie Strauss-Clark. I facilitate this committee. Nice to see you all. I'm just going to briefly run through our technology housekeeping. I know this is very familiar to most of you, so I'll go pretty quick. I have two slides here. The first is for our CRIS committee members, and the second slide is for community members and guests. So starting with CRIS committee members, please keep your mics on mute unless you are speaking. Advance, please. Please keep your video cameras on, particularly during the part of our meeting where we're going to be in discussion together. It's fine if you want to leave your camera off for the rest of the meeting, but toward the end of the meeting, we're actually going to have a brief discussion, and it's always helpful for all of us to feel like we're really engaging with each other if you can, if it's available to you to have your video camera on. Advance, please. We use raise your hand to indicate when we want to speak in these meetings. So to raise your hand, click on that reactions button, pops up a window, and you'll see raise your hand. Click on that, and I will call on you in the order in which I see you. We are committee members. If you would like to use chat today to share a comment or a question with me, you may send a chat to me, Jamie Strauss-Clark. And if you have any technical difficulties or questions related to the Zoom functions, please send to Chloe Chipman. You'll see on the screen there. Advance, please. And as a reminder, if you'd like to see as many committee members as possible on the screen, just click on that speaker view and change to gallery view. Advance the slide, please. All right, this is our Zoom etiquette slide for members of the public. So again, please keep that mic on mute for the whole meeting. Only if you sign up to make a public comment at the end of the meeting, I'll let you know when it's time to turn your mic off of mute. Advance, please. And members of the public, if you could please keep your video cameras off for the meeting. We usually have upwards of 100 people on this meeting, so it really helps us to be able to facilitate if just CRIS committee members have their cameras on for the meeting, and presenters, of course. Advance the slide, please. Or advance the, thank you. And then a reminder about that speaker view. You can just click on that and pop up gallery view to see as many CRIS committee members on the screen as you like. One more. Oh, we missed one. Sorry. Back up if you don't mind. I do want to let community members know I am not able to respond to your chats in the meeting. So occasionally I get chats from community members, but I really have to focus on the chats I'm getting from CRIS committee members. So I apologize. I'm not being intentionally rude. I'm just not able to read and respond to your chats during the meeting. Now we can advance. Couple more quick housekeeping items before I move on to our agenda. We have two ASL interpreters supporting our meeting today. You'll see Heather spotlighted on your screen right now. She'll be switching off every 15 minutes with Carol, who you've seen before. And they'll be spotlighted on your screen so that if anyone needs ASL support, they'll be able to access it. All right. And one last reminder, CRIS committee members, when you're speaking today, two things. If you could remember to state your name and organization and role there, that will help our community members remember who you are and how you relate to the CRIS committee. And also, because of our ASL interpreters, if we could all try to remember, and I know I forget all the time, to speak slowly and enunciate, it really helps them keep up with the interpretation. All right, that's it for housekeeping. Let's move on to our next agenda, which is to welcome you and review the meeting agenda. So today's meeting objectives, another treat in store for you today. We are going to hear updates from state agencies and subcommittees relevant to the CRIS. We're not actually going to have a personal story today. Unfortunately, that didn't work out schedule-wise. But we are still going to be grounding our work in the personal stories and experiences of people who encounter the crisis response system, because our panel discussion today is going to be focused on tribal behavioral health crisis response. So we're going to learn about what's happening in tribal behavioral health crisis response, and also how to ensure that the statewide work, the part that we're all working on, does not adversely impact or create barriers for the tribal work. We're going to spend a little time today discussing cross-system collaborations, including the Mental Health Crisis Call Diversion Initiative Pilot and Warm Transfer Protocol process, which I think a few of you have been really interested in hearing about. So I've previewed the data. I think you're going to be really excited to see that. And then we'll confirm action items and next steps and hear public comment. Advance the slide, please. I'll just take you all through the timing of all this. So we'll start with our panel discussion momentarily. That's actually going to be about an hour and a half so that we give plenty of time for our panelists to answer questions and leave about 20 minutes toward the end for our CRIS committee members to ask extemporaneous questions of our panel. Then we'll take a short break at 2:45, come back together at 2:55 to hear some system updates and give you an opportunity to ask questions, including an update on the technology platform. At 3:05, we're going to hear a presentation on cross-system collaboration, and then we'll have a group discussion about that, and then move into action items and next steps at 3:45, public comment period at 3:48. Couple of quick things here about the agenda. First of all, members of the community, at this point, we don't have anyone signed up to make public comment today. If you would like to make a public comment today, please send a chat to Chloe Chipman, and she'll take your name down. I will take as many folks as I can in the time we have for that 10-minute public comment period at the end of the meeting. And also, just to note, and I'll remind us again when we get to this point, when we are hearing the Tribal Behavioral Health Crisis Response panel discussion, CRIS committee members, if you have questions that you would like to ask the panel in those last 20 minutes, please send them in chat to me, Jamie, and I will take them down and pass them on to our moderator. All right, before we move, I do want to make one introduction. We have a new CRIS committee member. I am going to put her on the spot and ask her if she wouldn't mind introducing herself, but I'm delighted to welcome Kelly Wabel, who is going to be joining us to represent behavioral health crisis response with tribes. Kelly, would you mind just saying a few brief words about who you are?
So I'm Kelly Weibel. I work for Tulalip Tribes. I work as the Crisis Program Manager in Tribal DCR. I'm happy to be here. Thank you for having us.
Thank you, Kelly. And we're going to hear more from Kelly. She's also one of our panelists today. So very appreciative that Kelly was able to join the CRIS committee and join our panel today. I'm going to just take a quick look at my notes here and make sure I'm not missing anything important to share with you. All right, I think, I'll just say a couple more things about public comment process and then we'll move into our panel discussion. Actually, I will pause for a moment because I see Amber has a hand up. Amber.
Hi, Jamie. Thanks for just a minute. Sorry, I tried to grab you in chat, but I just want to make sure we had a chance to introduce. We also have our new 988 system coordinator, just started with the governor's office today, Jennifer Chancellor, and I similarly want to give her a chance to say hello and introduce herself.
Thanks so much, Amber. My name is Jennifer Chancellor, and I'm delighted to be joining the Office of the Governor. For the last 5 years, I have worked with the Healthcare Authority under the Medicaid Programs Division. So I'm just delighted to be joining the team and excited to jump into this work. Thank you.
Welcome, Jennifer. And I'm so, this is going to be a great start for your first day to dive into the CRIS committee. So thank you for joining us today. Amber, thanks for jumping in on that. I think we should be good to go. I'm just going to check and make sure all of our panelists are with us and ready to go. Bear with me just a second. Okay, yes, we look like we're good. So, yeah, so again, a quick reminder, members of the community, if you would like to make a public comment, please send your request to Chloe Chipman in the chat before the end of the meeting. I will be checking in with Chloe at about 3:45 to see if we have any signups. So please let her know by then if you want to make a comment. I think that covers us for today. So I am going to welcome our moderator, Vicki Lowe, who's going to introduce our panelists and share some information with you about tribal behavioral health crisis response before we dive into the panel discussion. Vicki.
Thank you, Jamie. I squatchy Vicki Lowe since nas to titlam nusklayam since na new hawk. My name is Vicki Lowe. I'm Jamestown Slalom and Bella Coola First Nations from Canada. I'm the Executive Director of the American Indian Health Commission, and I appreciate the opportunity for us to come here and talk about the work that's going on in Indian country when it comes to behavioral health crisis. I think I will introduce the panelists first, and then I'm going to give a really brief background because I think it's really important to understand some of the issues that we're trying to resolve before you hear the stories. So you met Kelly. We also have Councilwoman Rosalie Reevy-Jacobs from Lemhi Nation. Councilwoman Reevy-Jacobs, are you there?
Yes, I'm here.
There you are. Do you want to introduce yourself and then we'll come back?
Sure. Good afternoon, everybody. Quailicia Sunisnat. Let me see if I can get I'm not good with technology, so be easy on me. Quailicia Sunisnat. My name is Rosalie Reevy-Jacobs. I am a Lemhi Nation member, and I'm also a council member. So thank you for having me. I appreciate being here.
Thank you for being here to talk about the important work you guys are doing up in Lemhi. And Emily Arneson from the Port Gamble Squam tribe. Emily?
Yes, hello and good afternoon. My name is Emily Arneson, and I work as a suicide prevention coordinator for the Port Gamble Squam tribe. Thank you for having me.
Thank you. And Kelly, I don't know if you want to add anything else to your previous introduction.
Not right now.
Okay. And we're just so excited that Kelly took on being the first tribal designated crisis responder in Washington State. It's such a big deal. Thank you. All right. So again, I want to give just some brief background. I might go through these slides quickly, but I believe you receive a copy of them, and then my email's in there. If you have any questions, you can reach out to me. So next slide. So tribal governments provide healthcare, they provide public health. To us, behavioral crisis is a public health emergency. The systems that were built in Washington State really were not built thinking about how we would be working together, government to government, the tribes with the state system, and really did not fully understand or include what it means to be a tribal health jurisdiction or a Indian health care provider. Next slide. So the gaps were pretty huge. You know, we've been through regional support networks, BHOs, and now BHASOs, and they really don't understand how to work with the fee-for-service system in Medicaid or with Indian healthcare providers. Many times when our people present in crisis and they have fee-for-service coverage, the first thing that happens to them is that they get put in managed care without really informed consent of understanding what that means for their Indian healthcare coverage. Non-tribal providers, consider fee-for-services not having coverage, although more than 60% of American Indians, Alaska Natives in Medicaid are in the fee-for-service program. There's also a lack of access to voluntary inpatient treatment, and that really impacts our ability to help those in crisis. And then this is changing, but tribes traditionally had not been directly funded to provide crisis care. And I'm saying that's different now because of Kelly and the work that she's doing at Tulalip, and then a lot of the work that's happening under 988. Next slide. And this is the history of the efforts we've made. I'm not going to go through it, but starting in 1986, when the regional support networks were first introduced, our tribal leaders have been talking with the state, trying to fix things so that we could better coordinate for crisis care. American Indians, Alaska Natives in Washington State are also Washingtonians. They should have the same access to services that other Washingtonians have, but because of this really poor coordination between the two care delivery systems, it's just been a problem since it was implemented. And so we've had work groups, we've passed some bills. One of them was the Washington Indian Behavioral Health Act in 2020 that made it possible to have tribal DCRs. We've also worked very closely with Representative Orwell and Senator Dingra on the 988 work. So now we have the Native and Strong Lifeline and so many other things that we didn't have before. But this is decades of work to get to where we are. Next slide. But why is this important? So if you think about the implementation of managed care in the state of Washington and the years that happened during 2001 and to 2016, the rate of suicide mortality for American Indians and Alaska Natives in Washington state increased by 58%. And these statistics just really show us why this work is so important. Next slide. But we are resilient and our ways are resilient. Next slide. And so we can never forget that the things that happened to our people in the history have put us at a disadvantage when it comes to health and especially behavioral health. You know, genocide was committed against our ancestors. Officer Richard Pratt, who founded the, sorry, my grandkids are here, boarding schools, was famous for saying, kill the Indian, save the man, which meant, you know, take away the culture, cut our hair, don't let the children speak their traditional languages or have their traditional practices. Our practices were outlawed. All these play a part into how things are today. Next slide. You know, so we've learned a lot about adverse childhood effects over the years since the first study down in California that was done on non-Native people who were on private insurance. So thinking about that, and then on top of that, we have our intergenerational trauma in our communities. So we have very high rates of ACEs. The historical trauma repeats itself in cycles, and then the historical trauma where our communities experience traumatic events keep the cycle going. And so we've needed to work not just on prevention, but prevention and healing is the work to be done when it comes to behavioral health and behavioral health crises. Next slide. I'm almost done. Historical trauma is cumulative emotional and psychological wounding across generations, including the lifespan, which emanates from massive group trauma. And this comes from Maria Yellowhorse Braveheart, who is very well known for working on historical trauma. Next slide. There was actually a meeting that I was in quite a few years back where tribal leaders were really begging the state to pay attention to historical trauma and make sure that the services that are provided are understand historical trauma. And I know the person who said this didn't actually mean it this way, but they said historical trauma is not a thing. I think they meant it wasn't a billing code. But that was so traumatic for a room full of people who suffer from historical trauma to be told that's not a thing. So when we passed the Indian Behavioral Health Act in 2020, we actually codified the definition of historical trauma, and it's here. And that's not enough because historical trauma is really overwhelming if you just talk about it by itself. But we also talk about resiliency. Our people are resilient, you know, we're still here. So we've also codified the definition of that in RCW. Next slide. We have a lot of other related efforts to this. We're, you know, working on community health aides and behavioral health aides to be billable under Medicaid. We're working on primary case management entity to help support tribes providing care coordination to the people they serve. We're working on updating EHRs. We're working on Medicaid Transformation 2.0 with the state, so native hubs. Next slide. Behavioral health codes, helping tribes so that they can have their own programs, codes that aren't like the states, but help coordinate between the states. Next slide. So these are important because these are our laws, our constitutions, but we call them code. Next slide. And really helping others understand tribal authority and sovereignty, because when it comes to a behavioral health crisis for our people on our own land, the tribe is the expert, the people who work within the communities, they know how to take care of these people. And the rest of the system really needs to understand that they need to share information with the tribal governments and the Indian healthcare providers, that the tribes don't actually need those behavioral health codes to provide services, but they just help support them. And that the tribal leaders, their attorney and staff, are really the experts on the sovereign authority of the tribe, not somebody else. Next slide. We have the tribal designated crisis responders, Kelly. So far she's alone, but we're working on some more. Next slide. In this slide just shows the course that an American Indian Alaska Native would take from being in crisis to getting services. We're trying to develop a system where the blue is mostly where the American Indians and Alaska Natives end up, but we realize that there are times when sometimes they'll be with a tribal, maybe a tribal DCR, but they have to go to a non-tribal E&T because we don't have one yet, but we will soon. That if they go to Superior Court, or if they, so we're trying to develop the blue part of the services from the tribes. Next slide. And so for a tribal DCR, there's an opportunity for the tribes to choose how much they want that control. So in the current state, almost all of the tribes utilize the state system. So all the control is within the state system. But as you employ a tribal DCR, a tribe could say, we're going to have a tribal DCR on Wednesday through Saturday, 8 to 5. And then the state system still takes on the rest of the care when they're not available. And then as they can grow their program, they can start to take over more control. So we're trying to help the tribes move from being overwhelmed by all of a sudden taking on all this work, which Kelly will talk a little bit more about, but just coming in where they can and then building their programs as they build that capacity. Next slide. And now, because of the 988 funding, we're looking at funding for tribal mobile crisis teams. We have a work group that meets almost every Thursday and talks about this process. And I think a lot of tribes were already unofficially doing some of this work. So to see it get attention and formalized and funding is really great for us. Next slide. And that's more about the meetings that we have, that we're really like looking at how we do a lot of like tabletop exercises where like this person's in crisis, so what happens next and who comes and who does what. So it's just really great conversations and we get a lot of work done out of it, but using all the parts of the system. Next slide. And so just a reminder, when we have tribal behavioral health laws and policies, there's a lot of things that come into play. We have the tribes laws and their customs, there's federal Indian law, there's Medicaid laws, there's the State Involuntary Treatment Act, the managed care contracts the state have with the Medicaid managed care programs. We have tribal crisis coordination protocols now. And all of those come together to help us work together across all of the systems and coordinate. And so these crisis coordination protocols or plans are documents that do exactly what I was talking about, where they say, somebody's in crisis, who do you call? Can somebody come on tribal land? When do they come on tribal land? Who do they get a hold of? And all right down. So it looks a lot more like a public health emergency crisis. Next slide. And as promised, there's my email. So this is a really high-level overview. So if you have questions later after you look at these slides, please feel free to reach out to me. There's a lot more to it that that we're doing, but just want to be available if there are questions. So thank you. And I think we're just going to take the slides down and we can have our panel. Thank you. All right. So again, thank you for letting us come here and talk to you. We've been working really hard. There's a lot more work to do, but we appreciate the opportunity to be here and share the stories with you of the work that we're doing. So I'm going to ask I think 3 questions. Hopefully we'll get through all of them and we'll just like go through each of you. And I think Councilwoman Reby Jacobs, I'll start with you, if that's okay.
Sounds good. I'm sorry, my camera's not working for some reason.
Oh. Do you want to talk a little bit about what Lummi Nation is doing in the realm of crisis? What are some of the tribe's programs and priorities to support individuals in crisis, and maybe some of the innovations and cultural solutions that you're bringing in while you're doing that?
Okay, so for Lummi Nation, we brought on our own crisis team, and that consists of 5 positions. One position is the manager position, and then we have 4 peer support, and they're available to go on scene, help individuals as needed. And then they have the ability to rope in our cultural support. We have 2 elders at Lummi that their positions are called cultural coordinators. And so we've brought on our whole team to do everything in-house. So I think that answers your question.
Yes, thank you. And maybe touch on the drug task force a little, because I think that has some overlap.
I'm sorry, I didn't get that question.
Oh, can you touch on the drug task force a little bit too? Because I think it has some overlap with the crisis, or I might be wrong.
So our drug task force, that is still kind of in the works right now. We are hiring a coordinator soon. So it's we've kind of just tried to manage as we can with the opioid fentanyl epidemic. But we plan on bringing a coordinator on, and then we'll be able to really hit the ground running with our drug task force. It's not really up and running just yet. We have to hire on a few positions yet. So
thank you. Kelly, same question. What are some of the tribes, the Tulalip tribes, programs and priorities, strategies, innovations, and cultural solutions that you're incorporating into behavioral health crisis? Be right.
So tribal DCR is one of the newer things. We do also have a crisis team we're building. It right now consists of, I have 1 mental health professional and 1 peer and myself. We're hoping to double that number soon if we can find staff. But we're looking to try to utilize the behavioral health aides more in our behavioral health system, with our SUD, with our mental health, with our crisis, to try to kind of internally grow a system of people that are part of the community to be able to serve their own community. Because it's really good to support people, but it's better to give somebody a hand up than a hand out. And so we really want to support the community in peer support, in behavioral health aides. And then of course, DCR, we're working on that. I know there's other things happening with like more drug task force, like you mentioned. That isn't something I'm part of. But I know they are working on the opioid issues too. So really just how can we best support this community for what they need is the direction we're focusing.
Thank you, Kelly. And Emily, how about at Port Gamble? What are some of the communities, the tribe's programs and priorities and strategies to support people in crisis? And how are you incorporating culture and other innovations into the work that you're doing?
Yeah, I think, well, first, We have our facility here at Port Gamble is an integrated healthcare facility. So we have medical, we have behavioral health, so mental health and SUD counselors. We have peer support, we have a behavioral health aide, and we also have dental, all within one facility. And so I really think that this is where our gift and our strength is in caring for our people. We don't have, in terms of like high level of crisis care, we don't have that within our community. We're a pretty small community. And so as we've looked at our system and examined, having a mobile crisis team, having a DCR and facilities and things like that, we heavily rely on our outside system just because our capacity isn't such that we have, thankfully, enough crisis to warrant having something like that, because our integrated facility really does support people wherever they're at. Whatever door, there's no wrong door. We're supporting people in their needs. For example, we had an individual come in crisis, and we had our psych nurse available, but they had a really good rapport with their medical provider. So their medical provider was actually able to provide that support and de-escalate them, because we have this cross-training happening within our facility. And so I really think that's where our strength is and where we're providing that holistic care, because that's truly what our culture and community has done for so long, is look at the whole person. And so that's what we do here at Port Gamble. And then a lot of the work that we're doing beyond that is coordinating with our external partners. So working with our BHASO, which then contracts out those services of mobile crisis and crisis triage. And we've been working on that through the crisis coordination protocols, trying to really outline what we want to happen, how we want it to happen. There are a lot of challenges, which I'm sure we're going to get into that. But that is kind of where the emphasis of our work in the crisis system has gone, because we have so much, we have a lot of that front end work of just initially seating people, and we screen them and trying to do that initial care. So that's kind of where our energy is then put.
Thank you, Emily. And I'll just continue with you because you already kind of started that. What are the system barriers that you are working to address crisis in your community, including the outside partners work?
So there are, in terms of barriers, one, so we have our whole system where it's that someone to call, someone to come, a place to go. 988, we've been partnering with Native and Strong Lifeline, and that's been really great. Ultimately, we don't necessarily have control over who's calling and who's not, but that has been a great resource to us to continue to build that partnership and give our services for referral. But then that someone to come and a place to go are inconsistent and not necessarily always available. So we have one facility for crisis triage within our county that we could bring people to, but the requirements in order to be eligible to enter into that facility are lengthy and isn't necessarily that no wrong door approach. So we end up having people diverted to the emergency room anyways. And the care that they receive in the emergency room is really not what is needed. And additionally, with our hospitals, the communication back and forth, it doesn't happen. It's inconsistent. And we don't necessarily know where our people are, and they don't communicate with us. And so we've been working on different ways to address that. Our crisis coordination protocols don't necessarily, we're kind of deciding to take a approach where we're having individual agreements with hospitals and inpatient facilities so that that communication does happen, because I think that's the biggest thing, is that we need to use their facilities. We don't have the ability to have them in a facility right now. So just increasing that communication so that we know what's going on. We know our people, we know what they need. We want them ultimately to be back in our community because we can provide the best care here. And so that communication is really important. And that's a big barrier for us because that's not always happening.
Thank you, Emily. And I just want to tell or remind people that we did pass House Bill 1877 this last session, and it actually requires all parts of the system to, and we shouldn't have needed a law to do this, but we had to specifically call out that all the parts of the crisis system need to coordinate with Indian healthcare providers and tribal governments and give them information on their tribal members when they're in the hospital, in an inpatient facility. So this extra work that people have to do shouldn't be as hard as it is. And so I just want to call that out as a pretty big barrier. It's an education thing in our minds. So Kelly, same question. What are some of the system barriers that you're working to address that you're experiencing in your work?
So some of what Emily said, right? Knowing when people are in the hospital, knowing where they go, trying to make sure they're coordinated to when they're released from the hospital or treatment or whatever, that they have the community around them when they get back, right? How do we best support people that are coming back into the community so that they're successful? That coordination is getting better as I think part of it is because as the DCR, I'm a little bit more, hey, I've gone into the ERs shadowing. I have been lucky to have our county and VOA and the ASO have worked really great with us for training and to help, we're getting a flow for coordination of those things. But it took time, right? It took time to build those relationships and to figure out who does what is the best for the community. And I think those are where most of the barriers are, is like building those relationships, because communication, it seems like, doesn't happen automatically like it should, like the House bill states, right? A question I hear is, well, how do I know if they're Native or if they're Indian? Well, some of them are known members of the community. But outside of that, that's part of demographics that are usually something you gather in a hospital setting. If you don't, that's fine. But working to just coordinate those systems. We also, as the DCR, I can go through the county system, or our tribal court does also have codes for involuntary treatment. So I can go through either system. And part of what we're doing is working with different inpatient facilities. Okay, how do we make this work? Because, little education, sorry. What happens most of the time when somebody is detained is whatever county they go to, that court system takes over the court process. But that's not what Tulalip wants. Tulalip wants to be able to maintain their people in their court system. And a lot of times it's because there are more restorative, there's more wraparound services. And so working with the hospitals on how do we make that happen? Do we need MOUs? Do they need equipment? Whatever it is. And payment, right? Earlier, Vicki was talking about like making sure they understand, no, you're going to get paid. Just because they don't have A insurance or B insurance doesn't mean that they don't have insurance. And so a lot of it, I think, is just that communication and relationship building, and it takes time. It takes a lot of almost pushiness sometimes, unfortunately, that does eventually pay off. Like I said, I've seen with the local and state partners around here, it's gotten so much better, and I'm grateful for that.
Thank you, Kelly. Councilwoman Reeve Jacobs, same question. What are system barriers that you're working to address crisis in your tribe, in your tribal community?
So for Lummi, I think for starters, the hard part for us has really been hiring on of positions. I think since COVID, we really struggle with getting people to want to come back to work, and that's really affected our most vulnerable departments, that being like law enforcement, behavioral health, our medical. So we recently, I think about 8 months ago, we hired on a behavioral health director, and she has been so amazing. She's building our capacity, and she built this crisis response team. And we finally have all those positions filled. And now it's just really getting, letting the community know what services are available. And that it's 24/7 now, and we're able to do outreach and coordinating with the internal and external departments. So I think that's our biggest barrier.
Thank you. So Kelly, I'm going to go to you first this time on what recommendations do you have for this CRIS committee to ensure that state addresses crisis system barriers?
That's a hard one. Encourage communication, right? Don't be afraid to ask. And the other thing is approach, right? How do you approach a thing? It is something I learned coming in. So I am not native, but I am here to support the community. And so learning the difference, it is not your job to help them or fix them. It is your job to support the direction they want to follow. And I think that is the biggest thing I can share, is that how do you approach it? Approach it as a learning experience, and you're there for support, not to help or fix. Because the tribes are resilient, and they sometimes just need support in what they want to do and need to do.
Thank you. Very important point. Emily, same question. What recommendations do you have for this CRIS committee to ensure the state addresses the crisis system barriers that you see?
Well, I just want to say that, yeah, everything that Kelly said was spot on. But then also, I think that something that's come up is, training is important. There's two parts to it. So like training is important. And in terms of our crisis coordination protocols, something that we run into is that we have these high-level administrators who are here, communicating and talking with us about it. And we say, yeah, this is great. We're going to sign off on it. But then when we actually get to the door, nobody knows what we're talking about. It's not implemented. We need to have training through all the sectors about these things, because those are the people who are at the door providing those services. It's not just the high level people. It's great. It's great to be informed at all levels, but really those people who are at the door providing the services need to understand what the tribes are looking for, and be familiar with the process, so that when it does happen, they don't have to start searching through a document trying to figure out what we're doing. There's enough training to know that if you're working with somebody from this tribal affiliation, then this is what's supposed to happen. And what comes with that alongside of it is, again, the training is important, but also to be present with our communities. If you're working with them, come out. We want to show you our facility. We want to have a relationship with you. And that is what is going to make a difference in the care that's provided, because you're familiar with us. I've had many times where people end up coming out here and they're like, oh my gosh, I didn't know you guys had all of these things out here. It's like, yeah, we want to help you too. We're trying to do everything on our end that we can, so that both of our systems are supported and we don't have people cycling through and they are receiving the care that they need. And along with that, really continuing to move towards this no wrong door approach, because we're dealing with lots of different systems. We have the ER, we have crisis stabilization, we have EMS, we have public safety, we have mobile crisis teams. There's all these different avenues. And, you know, when people are in crisis, knowing which system to navigate, that's a challenge. And even people who are familiar with the system, it's a challenge to navigate it. And so the more that we work on it, I see it happening here with our integrated facility. If we have no wrong door, then people will receive the care they need. And they're typically not escalated and don't need a higher level of care. So we're not overwhelming our systems. And so it's really great that we have 911 and we have 988 and we're trying to, you know, direct people to the right area, but you're still giving two different options. And right now, people are more familiar with 911. They're more comfortable with it. They know what the process is going to be, and that's going to end up being in an emergency room. And then people have to try to get to this crisis stabilization. And so how can we integrate our services so that we're not, you know, oh shoot, you ended up in the wrong system. Now it's totally going to go wrong and you're not going to get anything you need. You know, we need to be able to have our systems work together in tandem to really make sure that people receive what they need, no matter where they call or who they ask for help from.
Thank you, Emily. And then Councilwoman Reeve Jacobs, what recommendations do you have for the CRIS Committee to ensure the state addresses crisis system barriers?
I totally agree with both Emily and Kelly. And then for just in addition to that, our recommendation would be ensuring care coordination between local, state, and tribal resources, government to government agreements so that we're all on the same page with the same expectations. So
thank you. And then from each of you, can you share experience from your community on partnerships with hospitals or inpatient behavioral health facilities? I think, Kelly, you especially have already touched on this a little bit. Do you want to go first?
So historically, we haven't had great relationships. Historically, it's been people get sent to the ER for evaluation, where they're back out in 2 hours, and we've had people that committed suicide after they got released, and nobody was notified they were released. Police took them in. They got released, and nobody knew. Nobody was notified, and that's part of the reason the DCR and the crisis team was a priority for this community. It is getting better. But there's still a lot of times where somebody's in the hospital or somebody's inpatient somewhere and they get listed as a missing person because nobody knows where they are. And then, you know, there's HIPAA rules, so family can't call and just be like, hey, is my kid there or is my cousin there? And so there are times, even now, I'll get a call, the detectives will be like, hey, we have this missing person. They kind of have a mental health history. Have you heard that they're somewhere? And so sometimes either I'll call around and be like, hey, this is my role, this is my job. We're just wanting to make sure they're safe. And luckily, a lot of times the hospitals can't tell you if they're there or not, but sometimes they'll say, I can neither confirm nor deny that they're a client here, but I can say they're safe. Right. And so, or the detectives have had more luck calling now too. But there again, that's that relationship building. They're listed as a missing person because nobody knows what happened to them. What happens if they get out and they kill themselves and nobody knows about it? So we are starting to develop better relationships with the inpatient facilities, with our local hospital ER. It's a slow process, but it is getting better. It's just taking some time because it has been a huge barrier to that continuity of care, right? I love what Emily said about no wrong door, because there really should not be a, oh, well, you went through the ER, and so that's not really us. You have to go see so-and-so, or, oh, that's a medical thing. You shouldn't call us. It's like, no, what is it that we can support you in? Okay, that might not be me, but I know the person who it is. And it decreases the escalation of crisis, of medical issues, of so many things, when instead of going, oh, well, that's really not me, you just, okay, how can I support you? And so working with hospitals, I actually get calls from the ER social workers now a lot more often saying, hey, we have somebody here that we believe is tribal or we know is tribal, letting you know. And then also inpatient, we're starting to get, that's more for the DCR though, coordinating so that they will take the tribal court orders, and they have a process on how that tribal member can stay within the tribal court system instead of going through the county system. So it's a work in progress.
Thank you. And then another reminder then, since House Bill 1877, that coordination should be happening. So as hard as these guys are working on this, you know, we really have to think about what is keeping the people from following the law. Emily, same question. Do you want to share experiences from your community on partnerships with hospitals and inpatient behavioral health facilities, either good or bad?
Yeah, this is a particular area where, you know, we've been working with the BHASO, and, you know, we've worked on those relationships, but now we're really kind of moving more into that piece with coordinating with the hospitals. And because we don't have agreements in place, you know, although it's a law, we're going to have agreements in place. We're going to have to create those relationships. A lot of what Kelly has done, you know, we're beginning to work more on. And it's going to vary from facility to facility how successful we are in that. One struggle has been medical clearance, and having to go through the ER in order to get someone. And we have all the faculties to be able to do that in our facility, but there's still barriers, so that they're telling us to go to the ER before we can have someone go to inpatient and all these different things. And so, you know, allowing us to, you know, do what we can do and get that person into the facility that they need to be in. Because when we have people in ERs, we have them wait for over 24 hours. We have them sent home when they really should not have been sent home, or kept when they shouldn't have been kept. You know, the hospital gets to decide when DCR comes in or not. So even if we call for a DCR in the county to come into the hospital, if the hospital decides they don't want that DCR in there, they can do that if they want. And so it's really kind of like, when we talk about our system and trying to create that continuity of care, we get to the hospitals and we're like, well, we don't, you know, we can hope that they'll do such and such, but there's really no, you know, guarantee that that's going to happen. And so it is just like what Kelly's saying, is creating those relationships. But something, you know, with that is, you know, if somebody were to move on, which we see turnover happen, then where do you start? You know, then it's like, oh, who's the contact? How do we, you know, how is it sustainable? Because we could do all this work, but then if we have that one person that really communicates with us well, move on, like that's not a sustainable system. And so we have to come up with solutions to these problems, which we already have the law in place that they need to communicate with us. But how do we it's fostering that understanding about, you know, the importance of it, that it's not, you know, from one person or the other. This is just overall culture change about communicating with our tribes and the importance of that. And that's what needs to happen in our facilities. It's going to take a long time, I think, but ultimately, like, I wish we didn't have to have the agreements, I guess. And, but that's the avenue that we have to take right now because the communication and coordination is just not happening for us at all.
Thank you for sharing that, Emily. And I am sorry. Councilwoman Reeve Jacobs, can you share some experiences from your community on partnerships with hospitals and inpatient behavioral health facilities, whether they're good or bad?
Yes, I echo what Emily has said. It's I think it really struck me when she said it's an overall culture change in mental health. It's really something that we're not anywhere close to yet, but we'll get there. We do not have a good partnership at this time with the hospitals. And as far as, it feels like there's no follow through with them. It feels like our people are slipping through the cracks. And then for inpatient behavioral health facilities, more times than not, there's no availability. You'll have to call 4 or 5 facilities just to get patients in. And so I'm hopeful. I feel like we're heading in a good direction now, but we also have a new tribal liaison that works at the hospital. So she's really going to help build that bridge so that we can coordinate better. But for right now, I would say it's not a healthy relationship right now.
Thank you for sharing that. And so, when we hear about these things from 3 different tribes in 3 different areas, these are institutional barriers. It's institutionalized racism, to be completely honest. And that's what we're up against. We've done a lot of work. Our tribal leaders have been working on this for decades. These guys have put hours in, hearing Kelly and Emily talking about the relationship building that they've had to do. All those kind of workarounds are institutional barriers. So that's what we're dealing with. You will probably see a bill, some legislation from the American Indian Health Commission next session to try and address the hospital ER situation. I don't know if it'll go anywhere, but the hospitals have been, as you've heard, a big issue where our people go there and they get released and nobody tells the tribe. And the tribe has all these services, these different tribes have all these services to provide for them. They know how to care, they know them, they know how to take care of them, and they're just getting dumped off into the streets. So that really has to stop. Sorry, and I just want to give our panelists a last opportunity to say anything else you want to say, and then we can open it up for questions. Jamie, are we on time for that? Okay.
You're great on time. You have plenty of time.
Okay, good. So, Councilwoman Reeve Jacobs, anything else you would want to add before we open up to questions?
I just want to say thank you for this opportunity. I really feel like this is we're at a turning point, and it feels good that we're going to head in the right direction. We're not where we want to be, but just having this open discussion and really being honest with one another is so important. So I thank you for that opportunity to be a part of this.
Thank you. Emily, anything else to add? I already have one question.
Yeah, I'm thank you for inviting us and helping or letting us be present in this space and just continuing to know that I can't speak for all tribes. I'm not going to do that, but we want to have that relationship, that government to government relationship where we have a seat at the table just like any other state would. Because we are recognized at that level. And so being able to continue to remember that it's not just asking for consultation or a second thought to be like, oh yeah, what would tribes do? We should have a primary seat at the table because of that sovereignty. And I'm glad that, we have the ability to come and speak about some of the issues that we're having within our nations. Thank you.
Thank you. And Kelly, Anything else?
I also want to say thank you for inviting us to speak. One thing something Councilwoman and Emily were saying in the last comment about the struggles and that community building. I think the hardest part for me was that I had to be really pushy, and it shouldn't be that way. And even there were times I'd call the ER and they're like, oh, well, it doesn't matter. We don't have an ROI. We can't talk to you. And I'm like, okay, RCW. And I had to cite RCW to them, and they escalated it up to their management. And there should be no reason that you have to be that pushy when it's law, right? When you're trying to support and help somebody in a crisis, you shouldn't have to be pushy just to collaborate. There again, especially when it's law. And so that's something to keep in mind, is just it is law, but it shouldn't have to be that way. But like I said, I do appreciate the opportunity to speak. I appreciate it that all of us were here. Thank you.
Thank you. And the first question is about practice-based evidence. So everybody I think knows the phrase evidence-based practice, but evidence-based practices are evidenced on not us. So we have practices that are so old from our ancestors that have been handed down, and we know they work because they've been working for thousands of years. So that's what practice-based evidence is. The question or the statement is, I would love to hear about practice-based evidence in crisis response, since that is unique to the way tribes think about evidence for intervention. Who wants to take that question first? Councilwoman Reeve Jacobs?
I don't know how to raise my hand, sorry.
It's okay.
I was just going to share that for us here, we have brought on 2 of our tribal elders, and they provide cultural support. I think I've already spoke about their positions, the cultural coordinators, but they are so important to our community members, and they definitely they have such value. And so that's something that we've done here to try to ensure that our community members are feeling supported in our cultural ways. And so, yeah, that's something that we've done ourselves.
Kelly, Emily, anything to add?
I would just say, in terms of suicide prevention, a big emphasis we've had is, our culture is our prevention, and talking about mental health and suicide is definitely becoming easier within the community. There's less stigma, but it's still a challenge. And so, a different approach, or an approach that I've taken is, facilitating just coming together and learning about the different cultural avenues someone can take, bringing them into the communities in together as a community and having options for different things that they can try. So having those events that bring people together is really on the front end of prevention, where we're not necessarily targeting a specific issue, but knowing that gathering, being together, whether it's working with cedar or beading or learning how to cook a meal together, those are the things that take care of is taking care of ourselves, and bringing each other together. So really emphasizing that more on the front end. And then within our system, our integrated care really looks at the whole person, and knows that's ultimately what's going to support in their treatment. And so that's kind of the approach that we have been taking in that regard.
So I know as part of our health clinic, we also have somebody that does Reiki and massage and acupuncture. Also encourage, like Emily said, community events and um, just connection to community. And when you do recommend, like, okay, so you're feeling a certain way, you're feeling an energy. Okay, so do you need to be brushed off? Do you need to go to the water, right? Things that are specific to the culture and what is most helpful to the person, um, instead of what might be considered best practices or evidence-based. Evidence-based doesn't always work on a community that it wasn't based on. So just adapting to what do you see and learn, right? As you work with the community, you learn what is evidence-based to have worked with that community. And I think that's the biggest thing.
That's a great point, that it might be different in each community. Some other things that we're working on that relate are the implementation of behavioral health aids, and making sure that they're Medicaid billable. And these are grow your own providers. They have a longer pathway to certification, and it just fits better with how tribal people work. We learned from, I think it was Wazoo, that when our Native people were coming to go to school to be a doctor, the first time there was a crisis at home, they would go home and not come back, because it's really hard to leave. And leave your family behind and your culture behind and go somewhere else. And also there's a couple of projects going on to support billing for traditional Indian medicine. And so the Seattle Indian Health Board has actually developed billing codes. And we're working on a credentialing process and trying to work with the healthcare authority on a state plan amendment for that. There's been a few other states that have amended their Medicaid state plan to include billing for traditional Indian medicine. So those are a couple of things we're working on. Let's see, it's very sad to hear about the hospitals. And we realize the hospital ER issue is more of a statewide issue and less of just the tribal issue, but it is really impacting our people. Another question, you've spoken about tribal sovereignty. What is something you wish the CRIS Committee and all state policy makers and lawmakers understood about tribal sovereignty and how it affects your behavioral health crisis response work? Who wants to take that first? Tribal sovereignty and behavioral health crisis response.
I think for Lummi, we know how to take care of our people. I think that maybe trusting us more, I guess, is how you could say it. And then just coordinating better. It feels like I said before, it feels like our people fall through the cracks. And so just better coordination and trusting us that we know how to take care of our own.
Thank you. Emily or Kelly?
I would second that, and yeah, just continuing to develop those relationships is fundamental to the behavioral health crisis system, and not an add-on. That it is part of the system. It's not an additional thing that we're going to do once we get up and running. It's a part of the process from start to finish.
Yeah, and that's a big one, Emily, is like they're getting tribal DCR. It's a brand new thing. But going through this process, it was like a lot of times people are like, well, how are you going to do things? Well, there's already a system in place. Like, I'm not trying to reinvent the wheel on how this works. It's the same system done by a different person. And so I think that's the biggest thing, is just remembering that we're not trying to build a whole new system. it is one system, but it's more specific to the community. It's a community-based system instead of a state-based system. I think that's pretty much the big difference that I see.
And I would say that tribal sovereignty means that the tribe has the right to govern their own people and manage their own resources. And there's a federal trust responsibility for the federal government to protect that. The state takes on some of that through the Medicaid program and programs like this the crisis system. And the thing is that when a tribe is doing something and it's not the way you would do it, it doesn't mean they're doing it wrong. That's just your perspective. From our perspective, we're doing what we can to take care of our people in the way that we know. So it is really important to have that open mind. I'm going to tell a quick story. I'm sorry, but this is not behavioral health, but it does highlight what happens when tribal sovereignty is not honored. In 2009, 2010, during H1N1, tribal sovereignty was not very well understood. And tribes, we take care of our elders. And so when the vaccination was being distributed, many tribes said that they would vaccinate their elders as well as pregnant women and children, which was the priority that the federal government made. Because of tribal sovereignty, a tribe has a right to make that decision. It's not anybody else's right to tell them they're wrong when they make that decision. They know how to take care of their people. And so that was not understood. And some tribes did not receive vaccine because some people decided they were doing it wrong, which only came from their perspective and their understanding. So a lot of harm can happen to our people when tribal sovereignty is not understood. Sorry, I hate telling that story, but it's the best way. I know, Michelle. I'm sorry. I'm not blaming you at all, but I know it's cringy to talk about because we've come such a long way since then. You know, the work we did with the state during COVID, where they actually honored tribal sovereignty for the first time ever in the history of the United States. So we've come a long way since then, but very painful. I talked about it's House Bill 1877. What do you think needs to happen? So we are working on an implementation plan, and so far it's been educate, 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 educate the AOC, educate the hospitals, educate the correctional facilities. So we'll be partnering with the Healthcare Authority, with DOH, with the AOC administration, the Office of the Courts, to get information out statewide to help people understand these changes and what they're responsible for. I hope that makes sense. And then do we have any suggestions about 988 and the Native and Strong Lifeline? I know you guys know about the Native and Strong Lifeline. We're so very proud of the work that's happened. I see Levi here. This has just been so important. And so from our panelists, are there any recommendations you have for this committee about the Native and Strong Lifeline at 988? Go ahead. I see you.
I think just coordinating care is really important. Yeah, I mean, that's what we struggled with it in the beginning. And yeah, just coordinating care is really important.
Thank you. Kelly, Emily?
That was kind of what I was going to say, is continue coordinating. It's appreciated.
Mm-hmm. Emily?
Yeah, coordinating is always good. And definitely, but communicating our services to callers, letting them know that they're eligible, or actually, since our eligibility varies depending on our services, if you think they could be they might just want to know about our services, just send them our way. And if we can't provide that service for them, then we are going to find someone who can. So just if they need a referral, just give it to them and we'll do the best we can to support them and get them the services they need. But I also want to do a shout out to 988 because I've coordinated a lot with Native and Strong and I'm very grateful for that relationship. And we actually had somebody who we were trying to serve, and it was an issue of eligibility, and we were trying to navigate the system and get that person the care that they needed, and we were able to call 988 and they were able to get set up with a virtual appointment within the week. And so, it really takes time to start seeing our community trust this line. I think it will continue to take time, but I'm starting to hear those stories of people trusting the line and it working really well for them. And we're really, really grateful for that. So I just wanted to give a shout out. Thank you.
Thank you. And then there's another question here. It's kind of long, but it's about evidence-based practices versus.
That was actually just, Vicki, sorry, that was a comment I was passing on from Bipasha.
Okay, so everybody can see that one?
Yeah, everyone can see that one.
Okay, thank you. And then the question for Councilwoman Reeve Jacobs, you mentioned difficulty in filling positions. The CRIS Committee will be talking about workforce issues at our next meeting. Is there anything the state could do to support addressing tribal workforce needs?
I would have to check with our behavioral health people on that because I don't really know the answer to that. My apologies, but I don't know what the state could do to help that. I think it's more internal. We have to make sure that we're paying people properly and making sure that people are happy to come to work and yeah, I think it's more internal than it is something that the state would have to do.
Thank you. Emily or Kelly, do you have a comment on workforce and support from the state?
I think overall right now, hiring providers of any kind, whether it's medical, behavioral health, is a challenge. Countrywide, nationwide, not just here. So yeah, looking at avenues to get people, that's a hard one because it is a big struggle. It's kind of universal at this point.
Emily, did you have anything?
Yeah, I mean, internally, I don't think, as it was said, it's a struggle everywhere to try to have workforce. But, we also are interacting with our county and state systems. And so, yeah, any ways that we can support, people sticking with positions, that is important, because, as I mentioned before, if we continue to have this turnover and we're trying to make progress in our system, it's like we start back at ground zero because now there's a new person and we didn't know that it was a new person. So then we weren't looped in. So even if it's just within the process, if there's turnover, like making that transition more smooth so that the progress we have made isn't completely lost, that we don't, even if it's that person, it's like, okay, this is my tribal person that I talk to. Can you make sure that this email gets passed on so that they get emails about what's going on? I know it's a very simple and practical thing, but kind of, if we know this is the reality of turnover or even recruiting, how do we, in that process, try to still maintain the work that we are doing and those connections and communication?
Thank you. We have created a behavioral health attestation process for tribal behavioral health agencies. And in the last legislative session, the bill was passed to have an attestation process for tribally operated inpatient behavioral health inpatient facilities. So we're doing that work. DOH has done a lot of work on trying to get through the backlogs and issues that we've had with some of our behavioral health providers. I think, you know, and that isn't specific to tribes. There's just a lot of people wanting to become providers, but the process has been difficult. I know the legislature has worked on that too. There are some federal rules about Indian healthcare providers that, again, both DOH and Healthcare Authority understand and follow. And was it Kelly that was talking, or Emily is talking about, the people at the top know, but sometimes the people who are actually processing things don't always know those rules. So again, education throughout the system is very important as well. Yeah. Any other questions for our panel?
Let me see. Well, we still have a few minutes, and so I would love to, if the panel is game, I would love to kind of open it up to our CRIS committee members and maybe hear from them what they learned from this conversation today and what their takeaways were. Would that be okay with the panel? All right, so CRIS committee members, would any of you be willing to share with our panelists and the rest of the community any big takeaways for you from this conversation today? What's something that surprised you, or that you thought, okay, when we get together in September and start talking about recommendations, I want to make sure I remember this? Anything you want to share there? Give you a minute to kind of process that question. Claudia.
I just want to say thank you. Thank you for being here today and providing information to us. Super, super helpful, and just amazing all the work that you guys are doing. We have, I'm Claudia Alegre, and I represent underserved communities, but I also work with CMAR community health centers. And many times in a residential facility, we give tribe members who come and want to be served at our facilities. And one of the things they feel we would like for them to go, to be served where the facility will have a little bit more sensitivity and understanding of the cultural needs. And sometimes the member will say no, but they don't want to go into some of the facilities because they want to keep the treatment away of anybody knowing they're being treated. So they say no because we have some of the community members, they know me. So how do you recommend that we can, that we can provide the service, but at the same time being appropriate in terms of what are the cultural needs and what are the services the member would need? So kind of, or maybe doing a consultation, or maybe, how do you recommend that we move forward?
So Claudia, it sounds like you're seeing some the stigma and fear of being in a close-knit community, having your most vulnerable moments exposed to your community members, and you're wanting to learn from our panelists how they might, if that comes up for them, and how they might address that in their communities. Am I hearing you correctly? Okay. Any panelists have a thought on that one?
So we do hear that, right? As crisis workers, we try to get them connected to services, and they're like, yeah, but my cousin or my parent goes there, and I don't want them to see me, or I don't want them to know my business. And so what a lot of times is we will recommend, like we have another tribe that's fairly close to us that has behavioral health services, and we'll say, well, this tribe also offers services so that they're still within a tribal community to get their services, but it's not their community. And that's one thing we do try to encourage. And then offering virtual appointments, offering other things where they don't have to come up where everybody can see them. so trying to work around that, because that is a thing, right? In a close-knit community, oh, I saw Uncle Joe up at the drug place, like, and it is a thing. And so we try to be very, very conscientious of that. But that's a couple of ways.
And I would add that there is a Native Resources Hub that anyone can call and help connect to the Indian healthcare delivery system, help connect people, so they might have some resources, or like a Native serving organization that's close by that maybe not be their tribe, but at least provide those more close cultural appropriate services.
I just wanted to add something really quickly to that. We got a new Lummi Tribal Health Center, and when we designed it, we made it specifically so people who are going to the mental health, behavioral health section have a kind of a discreet entrance, so that it's not right there in front of everybody. And so we try to be thoughtful when it comes to things like that, even with our care office, our substance abuse care office. We have that tucked away in its own little section so that people can discreetly use the services.
That seems like a great strategy. Thank you. Great question, Claudia. And it just strikes me that there are so many themes that carry across what we're hearing today and what we've talked about with the entire healthcare system. So I'm appreciating that this issue of stigma and close-knit communities is something that affects tribal communities and the communities that Claudia serves, and so many of the communities that we all are part of. Jane.
So first of all, thanks so much I always learn from Vicki and whoever Vicki brings. I think the most heartening thing is, Emily, the care model that the Port Campbell Sklallam tribe has developed is probably the care model that every person in the United States should have access to. And the ability to work with people before they get into a crisis and do that so effectively, I applaud your efforts to do that. And then in terms of most concerning, I actually already emailed Michelle and said, can we please talk to the hospital licensing folks and ask whether, given the hospital's obligations under EMTALA to provide emergency care, I do not understand an ability to say that you won't let a DCR into your emergency department to do an evaluation. That just sounds very odd to me. So, but thank you so much. Thank you so much.
Thanks for taking action already, Jane. That's great. Michelle.
Well, I just want to echo the thanks. I continue to get so much wisdom and learning from hearing from our tribal partners, and just I'm really grateful to continue to strive to be a better partner on our end as well. It made me think about well, kind of where Jane was going to, but thinking about the work and how centered community is, and how we want to help people be linked back to services, especially coming out of treatment. I'm wondering if, and I'm not a HIPAA expert, but wondering if we've tried about or had conversations about ways to encourage opting in, like adding to HIPAA forms. Are you a tribal member? Do you want your tribes to know that you're receiving treatment? I mean, we've talked about that. We could do it on, some of the calls too. We're talking about a parallel conversation, or other conversation we're having around 988 is like, how do we get youth to additional services that youth may be eligible for, right? So instead of like screening, it's like an offering of like, here's would you want to know more about this? So just wondering if some of those conversations have happened in the past, or if that's an area that we could also explore more too, on the state side, working with tribes to see if we could further some things.
And I think the question that we've came up with is, do you receive services from an Indian healthcare provider, which could be really, I think, non-invasive, but it's getting the people asking the questions comfortable with asking that, because I think it makes people asking about race and ethnicity, which a tribal citizenship is not, it's a political status, but that makes people uncomfortable. So could it be, do you receive services from an Indian healthcare provider? That's, I think, would be a simple solution. I don't know if any of the panelists have other thoughts.
No, I like that because most of the time you ask, who is your primary care provider? So it's not necessarily more invasive or than that. And so that's a good way to word that, where you're getting the information that is needed, but also not making people feel like they're potentially discriminated against.
May I ask maybe a logistical question here? So if they answered yes to that, then what would be the next step to connect them to their particular tribe of citizenship? Because one of the things I heard in the panel discussion was how important it is for the tribe of membership for that individual to be able to keep track and serve them, support them.
I'll just tell you this, if it's the hospital, they certainly know how to build the tribes for people. So to say that they don't know that these people are tribal members is a pretty big stretch. So we actually borrowed some language from the Indian Child Welfare Act, and we put it in the 1877 that says oh, dang it, I'm going to forget the right words, but if they have a reason to know someone lives on a tribe or is connected to an Indian healthcare provider, that they should be connecting with that Indian healthcare provider. So reason to know is not just answering that question. It could be their address is on the tribal reservation. That's a big giveaway. There are certain last names, belong to a tribe. So that's reason to know. Yeah.
To use the same forensic skills they use to bill. To identify
if they could figure out how to build the tribe, they should be able to figure out how to connect back to the Indian.
That would be some good cross-system collaboration, right? If they could
talk to their billers.
Yes. Kristen.
Yeah, I've been thinking about our personal story from the last CRIS meeting. We had Leah come and share her story about her son, Amias. And one of the big points in her story was that after he was in a detox facility, he got sent to an unlicensed facility where his hair was cut. And this was a traumatic incident for him because he is Native. And just thinking about how that trauma could have been easily avoided if the detox center had identified at the time that this was a Native person, and they could have connected him with the services that the tribes in the area provide, even though he's not a member of any of the specific tribes here. Really just came up a lot for me when hearing the panelists talk about the importance of communication and coordination with the tribes, and how that was a big step that was missed in the story that Leah shared with us last time.
Thanks, Kristen. I think what I'm also hearing, to build on what Kristen just said, and I'm curious what the panelists think here, is an understanding from providers in the systems outside of tribes and a respect for how important one's cultural practices and community are to their mental well-being. And I'm hearing that's part of building those relationships and connections with external providers. Am I tracking that? Is it kind of boiling down to that? Or is there another way you would characterize that?
I think that I'm also not a tribal member. And I'm very grateful to be able to serve the tribe. And something that has come up, as you know, I have prepared to work for a tribe because I knew that's something I wanted to do, and I've continued to do that through working with the tribe, is we talk about cultural competency, but what's more important is cultural humility. That is what's going to last you through the system. That's what's going to change our systems, is cultural humility, knowing that you don't have the answer necessarily, and that you should ask. And you should first come in with listening, with being present, with creating empathy and understanding with whoever you're working with, whether that's providing direct care, whether that is working with people in coordination and creating plans. And, we all have to have that, that towards each other. That is what's going to change our systems, is having that cultural humility wherever we go, working with whatever community we're working with. And how we truly provide the services that people need, not what we think that they need.
So well put, Emily. And I saw lots of nodding heads while you were talking, so thank you for sharing that. I think that any other comments or questions from the CRIS? I just want to echo so many other CRIS members with a big thank you. Oh, it looks like, did Councilmember Reeve Jacobs have to drop off? Yeah, it looks like. I'll send her a note later, but Emily, Kelly, thank you so much for. Oh, I'm sorry. Are you still there?
I'm here. I'm just on my. I'm on my phone.
Okay. Well, I think big thank you to all three of you for spending this time preparing for this and for sharing such great information and insights and experiences, and especially big thank you to Vicki for planning this, inviting our panelists, figuring out what the questions will be, partnering with us on this to bring this information to you, and for just being such a tremendous partner on this behavioral health crisis work. I feel like this has been really illuminating. And as we go into kind of the CRIS Committee developing its final recommendations, I believe the outcomes from this discussion today will be really top of mind as we think about how we can both amplify and avoid adversely impacting or hindering or creating more barriers to the great work that Tribal Behavioral Health Crisis Response is doing. Vicki, is there anything else you would want to say?
I do have one comment that I really want to make, and it's that, this work with the CRIS Committee has been one of the best experiences with the state government, really honoring how to appropriately work with our tribes in Washington State and the urban Indian health programs. HMA has done a great job. When we met with them in the beginning, we gave them a bunch of homework to do. We're like, don't come to this meeting and with the tribes and make them tell their story from the beginning again, because that just, again, is an institutional barrier. We have all these documents, we have all this work we already did. Please read it and then come prepared with that knowledge. And that really happened. In the process, we have a tribal-centric behavioral health advisory board, which hosts the 988 tribal subcommittee, the process with Betsy and Nicola coming and talking and really incorporating the words of the people who do the work into your documents has gone in a way that I've never seen before, to be very honest. And I'm not exactly young anymore. So, I've been doing this work for almost 30 years. So this has been a really good experience. And I just want people to know that. Thank you.
That means the world, Vicki. Thank you. I wish Nicola's on, much deserved vacation. I wish she was here to hear you say this, but we're recording, so she'll get to watch this later. All right, we're a few minutes ahead of schedule, believe it or not. That's a rare treat for us. So I'm going to give you a bonus 5 minutes of break because we're going to be moving into different set of presentations, and I want to make sure all of our presenters have an opportunity to be here. But let's give a big virtual applause to our panelists and a big thank you again. And I'm going to invite everyone to be back. Let me just make sure I'm picking the time right. Yes. Be back on camera at 2:55 p.m. and we'll start with our next agenda item. Thanks, everybody. Hey, it's 2:55, so folks could turn on your CRIS committee members, turn on your cameras as you come back on. That will help me know when it's time to get going again. Or know that you're ready to get going again is what I meant. Okay, excellent. All right, so we're going to move now into our regular standing agenda item system updates and Q&A. You should have received the newsletter a week ago with all of the updates on agency activities and subcommittee activities since we last met. We do also have an update for you today on the technology platform. So we have Bob and Kyle from HCA. Bob, Kyle, I'm not sure which one of you is going to be presenting the timeline.
I'll take care of it here today.
Okay.
Kyle's online, and he will certainly jump in if I need some help. But I'm going to try to keep it simple for you here today and stick to one of us.
All right, fire away.
Okay, wonderful. Hey, thanks, folks. I'm really, by way of introduction, first and foremost, my name is Bob Beamer, and I recently joined the 988 program team on the HCA side about 2.5 months ago. So steep learning curve, and this schedule that I'm about to share with you is one of those things that I've kind of had to get my head around. So I understand how complex it can be, and I'm going to try to pare it down to probably the key things that you'd be concerned about. I understand that there have been a lot of questions over time about the schedule and about the phases and about what has to happen to make this solution happen. And so I really am excited by this opportunity to walk you through this timeline at a very high level, and more importantly, kind of explain to you some of the key things that have to happen in order to get this system up and running. This particular timeline that you're looking at right now is a newer version that was created following the last legislative session in March. So it incorporated some changes that came out of that legislative session, specifically additional requirements and an extension of the timeline associated with Senate Bill 6308. So that slid our timeline by about 18 months, and that's reflected in this new schedule. So if some of you have seen an older version of this, just know that this one has been radically changed in March, but not fundamentally changed since then. So yeah, there are a lot of things on this chart, and we use this operationally to kind of track where we're at with different things, and we're moving a lot of the smaller dates around. But what I want to draw your attention to here today are, like I said, the key things that happen or that have to happen in order to get us to this place where we can build and implement the 988 solution. So I'll break that down into a couple of component parts, tell you what they are and when they're really running. If you look at the schedule, the green box Q2 24, that just ended. So that would have been the quarter that ended in June. We're at the beginning of Q3 2024. And the big thing that we'll be doing between now and December of 2024 is what we're referring to as a feasibility study. And what that feasibility study will do is leverage previous research that's been done relative to this project and potential solutions. It'll look at multiple approaches, including software and services provided by Vibrant, which I think most of you or many of you are familiar with from previous discussions. It'll also look at other emergency networks and infrastructure and technology that might be applicable there. And it's also going to involve an assessment of approaches that are currently being used by other states with their 988 systems. So it's going to take a holistic look at all of the different things that are out there that might be able to be incorporated in Washington's solution. So once we understand what's feasible, what's doable, and what's not doable, that's when we spend the bulk of 2025 conducting a request for proposal, an RFP. So what that does is it takes kind of a two-step approach. One, developing and communicating the requirements to the vendor base for our system. So telling the vendor base, hey, this is what we need you guys to build for us. That's going to run January to June. So basically the first half of 2025. Once then we've communicated outward to the vendor base as to what we need, then the vendor base itself will have about 6 months, June to December 2025, in which they develop their proposals, whether they want to bid on it or not, first and foremost, and then as part of their bid, how they propose to address our needs, what they imagine they can cobble together from different tools, different resources, what they imagine they can leverage from previous engagements with other customers, and how they will meet our expectations. So basically then after that whole year of developing, communicating requirements, and then receiving proposals, we hope to select a vendor in December 2025. If you look on the schedule, you'll see a reference to the ASB. That stands for Apparently Successful Bidder, and that would be the vendor that we select to spearhead the development and the implementation of this project. So once that decision's been made, and again, right now we're targeting December 2025, then it'll take a little while to get that vendor onboarded, get them up to speed, get them oriented, and get all the contracts in place so that we can pay them properly. So we anticipate that happening, as you see here, January through April of 2026. So ultimately then, that's all of the administrative work that has to happen in order to get to a place where we even start building the solution. That work will begin tentatively right now, second quarter of 2026, sometime around April, May 2026. And after some development time, as you can see on the far right of the schedule, we're anticipating a rollout of the initial solution in around the April 2027 timeframe. We do anticipate that this will be an iterative approach, a phased approach. That April 2027 solution is not going to be the complete solution. It's going to be a foundational solution that covers those needs and those requirements that have been refined between today and the selection of that vendor through the phased approach of the feasibility study and the request for proposal. So there's a lot of information that will still be gathered as we engage with potential vendors and the selected vendor that will help us understand better what that phased implementation will look like and which elements will come online when. So that's kind of the high level overview right now. The idea being here again that I can help you all understand the things that have to happen to get this system in place and give you an approximation of how long those things will take and how they're all stitched together. So I think at this point, I'll stop talking and see if there are any questions.
We'd have a couple of minutes for questions from the CRIS committee, either on the technology platform or if you have any questions from what you read in the newsletter. Any questions? Okay. Thanks, Bob.
Thank you again for the opportunity. I greatly appreciate it.
Tisha, can I just quickly ask you just to kind of, and maybe I should have set this up. See, I'm going to make sure Tisha's back on before I ask the question. Oh, there you are. I was scrolling through all my people here. Tisha, really quick, could you just, I know most of our CRIS committee members have been along for the ride when we talked about the tech platform, but would you mind just reminding, and also any community members who might be new to this process, just a high level, what this will do for us once it's working in 2027?
Yeah, absolutely. And all of my tech people, if I say this wrong, jump in and correct me. But from my layperson point of view, a programmatic point of view, it's really to connect all of the background systems so that it's easier for connections to be made. So we often hear about, I think we just had great examples today talking about the importance of communication and the importance of making sure information flows from one person to the next. What this system is attempting to do is to create a technological system to help with all of that process.
That's a perfect explanation. Thanks, Tisha. So any questions, folks, about this timeline or from the newsletter? So really quick before we move on to the next item, Michelle, today is an important day. Levi reminded me you knew, but I had forgotten. So can you remind everybody what this is the anniversary of?
Yes, today is the 2-year anniversary of the 988 three-digit dialing code going live. So really so important to kind of pause for a moment and recognize all that all of us have accomplished together for the next 2 years. I know we're all always on our mind for where do we want to improve and where do we want to get to and how do we want to build out of the complete crisis system, including, like Tisha just said, Tisha and Bob shared, the kind of technology behind the scenes to hopefully make things more seamless for people in the system and help different people who have a right to know information have access to that information. But right now we should pause and for a moment. And in our state, we've had incredible success, and it's to the credit to our broad system partners, the 3 call centers in the state, our BHASO partners, our state agency and sibling agency partners. So many people, all of our crisis system people on the front lines, our tribal partners, our Native and Strong, Lifeline, just so many different things that we have done that have put Washington State out ahead and really taking on the opportunity of a 3-digit dialing code to nationwide to really improve the continuum of crisis care in our state. And a few things I just want to say to call out for all that success we should all be so proud of. Washington State has consistently had an in-state answer rate where our running average is about 91% right now. So that's how many calls, texts, and chats are answered in Washington State. We are ahead of the national average by about 3 percentage points right now. So it just, I think, continues to show all the work we've done in investment, the investments the legislature has made in our system, to really support having a well-connected and funded system to do this work. I also want to just share a few numbers of what's happened over the last few years too, and who we have served. So I'm switching screens here to some information Lonnie just shared with me a little bit earlier today. In July 2022, the first month that we have a full set of data after 988 launch, Washington received about 6,000 calls, about 350 chats, and about 340 texts. So in June of this year, 2 years later, we've received over 9,000 calls, so that's up from 6,000, over 1,200 chats, up from 350-ish, and over 3,467 texts, so over 3,400 texts. And before I said that text was about 340. So we just really see this incredible increase of volume as people become more aware of 988, and hopefully all of us working together to increase the trust and with the response on the other side. So increasing the knowledge and awareness and trust in the services we provide. So, and those numbers don't include transfer of calls from 988 to 911, which we're going to share about a little bit more about here. And that's just how at the federal level they're being counted. So something for us to continue to work on. Last thing I want to say about our call volume is the Native and Strong Lifeline. So our tribal specific 988 line has also seen significant increases. It launched in November 2022, a few months after the first of 988. And that first month, they received 232 calls. And in May of this year, which is the most recent data we have, they've received 535 calls. So just really continued tremendous growth in providing people services in our state. So just there is really, really wonderful to know that all of us are working to make sure people know that there is help available, confidential, free, 24/7, and all the work all of us are doing behind the scenes to continue to provide high quality services and looking towards the future for how we want to continue to improve.
Lots to celebrate. Thank you, Michelle. And thanks for pulling together all those facts. to remind
Yeah,
us.
I'll put them in the chat, Jamie, too. So
Yeah,
we can
I'll
share them
send
out,
them like
since I
everyone.
read out a lot of numbers, but that would, yeah.
That's awesome. Thank you so much. All right, so now we're going to move on to our next agenda item. I've been promising you some discussion and learning about what Department of Health is doing with cross-system collaboration. So I'm going to turn it over to Elena Perry with Department of Health. I'm just going to tell you before I turn it over to Elena, I want to just give you a quick overview of how this agenda item is going to go. Elena is going to give you a presentation that's going to share some data that they've collected at the midpoint of a pilot project on 988 911 collaboration and handoff. And then we're going to hear from our call centers. And then we'll have some time before the end of the meeting for the CRIS Committee to do some group processing and talk about and ask questions about what we're learning today from Department of Health. I just want to pause and check in. Christine, do we have any signups for public comment?
No, not as of yet.
Okay, so it looks like we should have a few extra minutes for our discussion at the end of the meeting that we can take. So Elena, take it over. Thank you.
Yeah, thank you, Jamie, and thank you to the CRIS for the time today. I'm Elena Perry. I use they and she pronouns. I'm a 988 program supervisor with the Department of Health, and I'm also a person with lived experience as a suicide attempt survivor. Well, today I'm just here to provide you with an update on some of our pilot projects, the 1134 funded mental health crisis call diversion initiative, or MHCCDI. Pilots and ensure that you all are aware about our next steps with this work while we try to move towards a no wrong door approach to mental health crisis services. You can go to the next slide. I think Jamie did a good job cueing this, so I'll pass this agenda for now. We can go to the next slide and I'll give a brief overview of diversion. So the diversion initiative as a whole really aims to meet people where they're at. So folks are still calling 911 despite availability of 988 in the instance of a mental health crisis or a substance use crisis. And some of those calls we know may be better served by 988 or better served by other entities in the crisis system. So this effort funded through House Bill 1134 began in January of this year. Planning began in 2023, but we planned to do a year-long pilot, January 1st of this year through December 31st, and then evaluating that pilot with a report coming out in June of 2025. Though those partnerships are going to be continued in their funding, currently we're set to continue through June of 2025. So the partnerships I'm talking about are partnerships between Washington's 3 988 Lifeline crisis centers and our three specific primary public safety answering points, PSAPs or 911 centers where 911 calls go. The state has over 65, but 65 primary PSAPs. So this is a small portion of those PSAPs. And we're working here to create memorandums of understanding. Each of these partners work together to create memorandums of understanding that had clear set call identification criteria. So they determine what calls 988 could handle from 911 and develop a process to transfer those from one entity to another. These partnerships also supported some embedded partners. So 988 was able to physically co-locate with 911 in some of these partnerships. And what we're hoping to learn from this effort, well, a number of things. First, kind of the best practices for cross-training our staff, best practices around screening on the 911 side, screening criteria for crisis calls that could be appropriately diverted. Some how-tos around how to develop best partnerships, practices for best partnerships between 911 and 988. And then also thinking in the long run, how can we serve Washington State as a whole and do so sustainably, including projecting, how many calls can we get from 911 to 988 and make sure we plan appropriately in terms of that volume. What we learned very quickly in this pilot and also from statewide 911, I think Adam and Katie are both on today and they'll be able to speak to their experiences soon as well. But we learned that maybe an embedded partnership might not be the best fit for every 911 PSAP. They might not have the physical space and there might be other concerns there. We need to find alternatives or explore alternatives for that effort to make sure we can still best serve people in crisis calling 911, but maybe not through embedding in every single primary PSAP. So we applied for a grant from NASHBID, the National Association of State Mental Health Project Directors. It's a mouthful, sorry, through their Transformation Transfer Initiative. And we were given a small grant that we've put into contract with HMA. And HMA is working to develop an environmental scan and then conduct a number of community and tribal engagement workshops to understand from our community's perspectives, what do they want to happen when they or their peers, family members, community members call 911 in a mental health crisis. Then they'll conduct workshops between 911, 988, the Behavioral Health Administrative Services Organizations, or BHASOs, and other key partners to develop basically a floor, a set of protocols that could be adapted by each region and implemented to fit the needs and the resources that already exist, with understanding of existing work from the Healthcare Authority around regional crisis dispatch protocols and tribal crisis coordination protocols. Ultimately, they'll also develop a train the trainer program to help 911 telecommunicators embed these warm transfer protocols. We can go to the next slide. So we have just finished our midpoint evaluation, and we just wanted to share some high-level insights that we've gotten to date, both quantitative and qualitative. But we've also planned to share with you more in-depth slides via email after this meeting, so you'll be able to see more in-depth, more of the quotes and outcomes from this midpoint evaluation. Right now, we've taken well over 2,000 calls across the three partners. So here's some diversion data to date so far. We can go to the next slide. And we've also seen an increase in confidence from 911 and 988 call takers. And then by that, I mean confidence about the impact of this work, confidence in understanding around their roles in supporting that work, confidence in relying on their supervisors to support them around their concerns, and confidence in being able to support or address the needs of help seekers. So this is great to see, but we are not without our challenges or concerns, and we'll cover some of those shortly. We can go to the next slide. Some early successes that we see. We know that we've seen a reduction in strain on 911 in many ways. Call takers or telecommunicators from 911 have noted that they've been able to support their callers in the future when they're calling in with suicidal ideation or hallucinations to instead call 988 directly for a future crisis. And also time spent with 911 mental health crisis calls have resulted in long-term impacts to that person's support. So people have increased in their confidence to be able to provide appropriate resources and referrals to people in crisis. So linkages to longer-term care. You can go to the next slide. And really here we want to highlight some of the qualitative challenges that arose. And there are quite a few. Some that we've predicted and did our best to plan for, we'll continue to plan for, and others that were newer to us. So these are great. This is exactly what we want to learn from the pilot, these kinds of challenges that we can navigate early on. One that especially 911 callers, call takers, identified was that some folks who were calling in a mental health crisis, when recognizing the resource being referred to them, when they're referred to 988, they'd feel uncomfortable with the idea that they were being transferred to a crisis lifeline. We attribute that somewhat to stigma. They're feeling as though they're being dismissed or their needs are being dismissed. And some of that might be rooted in maybe a misunderstanding also of what 988 can do. But that's one of the challenges that has already been brought up. Another is for our 988 counselors in addressing the needs of folks who are experiencing hallucinations or delusions. It can be difficult to engage folks in safety planning and problem solving in those cases. And so that's a training area that we'll touch on in our next steps in a moment. Resource limitations. These are not 24/7 pilots that are fully staffed, and they're only in 3 PSAPs. So confusion about pilot hours and concerns about longer wait times have been brought up by 911 and 988 staff. The need for additional training was also brought up by both 988 and 911 supervisors. They feel equipped to do this work and feel that their cross-training has been supportive, but for some higher levels of acuity calls at this consistency might be difficult. Another is the challenge with insufficient physical space, especially in one of our partnerships, followed by collaboration. This was also another 988 and 911 supervisor challenges, making sure that folks know each other's roles and capabilities across 988 and 911. Another challenge that arose was that some folks were struggling with, especially at the 988 side, callers who do not wish to engage with mental health help or resources or referrals being offered. Technology remains a challenge, and we're hoping that the tech platform you just heard from Bob about can help us with that a little bit, but lack of interoperability can be a challenge when moving one case from one center to another. Additionally, call identification. There's been training needs, especially for 911 call takers, where additional support for understanding call identification criteria has been necessary. You can go to the next slide. I'll just highlight this in the interest of time. A few training related challenges that we're looking to improve. And I can highlight Frontier Behavioral Health has just invested in additional motivational interviewing courses specifically to support folks with higher level of acuity crises, but also for people experiencing those severe hallucinations or delusions. So there's a number of different things we're going to implement in the course of the next 5-6 months, so the course of the pilot, and others that we'll be able to learn from as we develop out and look to expand this work. We can go to the next slide. I've spoken a little bit to what's next, but there are a number of community listening sessions and tribal listening sessions. I will note this content is going to be at the Tribal-Centric Behavioral Health Advisory Board tomorrow, and we may discuss adding a session due to a conflict for the July 25th session listed here. Just wanted to note that. But additionally, I wanted to make sure you all knew you can send out those links to the community listening sessions or reach out to us if you have additional attendees for the tribal listening sessions that you'd like to invite. But all of our next steps here are really in service of looking towards sustainable and long-term expansion of diversion efforts, both to the PSAPs we're working with currently and to other PSAPs, really with a clear understanding of voices from our community members and tribal representatives. But with that, I'll actually pass it to the real experts here, our crisis centers. So first, I'll welcome Crisis Connections, and I'm going to ask each of our speakers to speak to the question, what is your biggest takeaway from the midpoint data and your own experiences and observations to date? So I believe it's Diane up first, if you're on the line.
Sure. Hi there. Diane Mays, Clinical Director for 988 Crisis Services at Crisis Connections. And happy anniversary, everybody. And super excited to be here on this day particularly. So I'm glad to be a part of this conversation. Yeah, I mean, and when looking at this data and just assessing the program overall, I really would say, our biggest takeaway is that much of this data that we're seeing today is consistent with our experience that we're having, recognizing this is a pilot, this is a new program where we're bringing a newer program. Clearly 988 is only 2 years old at this point in the iteration that it's in now, and coming into our PSAP Valley-Com's existing facility has been a learning experience for all of us, and recognizing there are going to be nuances along the way that we'll have to address. And so we continue to meet monthly with the leadership team to talk about we talk regularly about any concerns that may come up along the way, as well as have ongoing meetings on discussing challenges or process improvements, including training and basically collaboration across our teams. We know there are some limitations with the technology and with such things as the disposition codes and what qualifies as a mental health call. And so really partnering together to sit at the table and have those conversations has been really key to our growing and establishing and developing the program along the way. And so I would say a lot of these key points we already currently are talking about or actively addressing, and always looking for ways to establish best practices built from models that we both have as organizations and what we're learning across the state with other centers, as well as obviously our input from Vibrant and other national platforms as well. So really bringing those pieces together and to the conversation has been really helpful in helping us address this. And, you know, also I'd like to express too the enthusiasm for the program, at least, you know, from our teams. I was really great to see that from the call takers, that they understand the value and the why in doing this work. And so we know that that will go a long way to enhancing our relationship and continuing to expand our outreach to callers, or our services to callers in need. And the other piece I wanted to add was our program is also unique in that we have 211 INR specialists embedded in our program as well. And so we can really take that holistic no wrong door approach when a caller is transitioned. They, you know, are finding out that their challenges or their crisis may be caused by an essential needs circumstance that's come up for them. So we can interact with them on the 988 side, de-escalate the caller, get them to a place where we can also transition them to 211, or they can be transitioned directly to 211 from Valleycom to address those needs in the moment and help alleviate that stress of that potentially impending crisis that could be happening or is occurring that's impacting them from that perspective. Those would be kind of my key takeaways at this point. Happy to share more as needed.
Well, thank you, Diane. And to the group, we will have, I believe, some time for Q&A. So you'll be able to ask myself and the other panelists today some questions. But next, I'd like to welcome Sarah at Frontier Behavioral Health.
Hello, everyone. I'm Sarah Shoemaker. I'm the director of 988 at Frontier Behavioral Health in Spokane. I'd say Diane really hit it out of the park in everything she had to say. You know, the data that we saw wasn't incredibly surprising. It really aligns with our experience so far, particularly the comments made about training and feeling prepared to help callers who are transferred from 911 to 988. I think what we learned really quickly was that individuals who are in a behavioral health crisis accessing 911 are doing what they think they're supposed to do. And that is reach out for urgent help for a crisis that feels like it needs an urgent response. I was listening to a comment Michelle said earlier when she was talking about our success as a state with 988, and she mentioned knowledge, awareness, and trust. And those are the exact recipe, the exact ingredients in this recipe where I feel like we've been successful. We worked together with our PSAP to try to sort of forecast what the needs were going to be. We tried to understand the limitations and the strengths of each of our services. And then we became more and more aware of how we might be able to help. But ultimately, where we are finding our success is in that trust between the two of us. And I think that was established early on. And that was because we were allowed this opportunity to work with each other in real time. We hosted them, they hosted us, all with this premise of how can we learn the most from you and you the most from us to help the most amount of people that we can. And like she mentioned earlier, it's all about these partnerships that we've developed in the spirit of getting people the appropriate response for the appropriate need. Another thing that is incredibly true about the data is these concerns about maybe we're not doing enough, and maybe that's because our pilot isn't operating 24/7. And I do think that there's plenty of room for further expansion of that work. But I get a little soapboxy on this one thing. I think there is also opportunity for expansion in our communication when we talk about 988, because although we are incredibly skilled at helping individuals who are maybe experiencing some sort of suicidality, that's not our only purpose. We want to help people who are in crisis, and we want to help people who learn from utilizing our service and say, hey, that's right. When I'm feeling these ways, I don't need law enforcement. I don't need the fire department. I need this type of support that 988 is able to provide. Thank you.
Yeah, those are great points, especially seeing the, considerations around, stigma as a barrier for transfer, those kinds of things that can be accomplished in communications and in our campaigns are really helpful insights. And next we have Levi with VOA.
Thanks, Elena, and thanks everyone for covering things so wonderfully. I'm Levi Van Dyke. I'm a CRIS Committee member, and I'm the Chief Behavioral Health Officer at Volunteers of America Western Washington. Just hoping to have Courtney Caldwell here speaking with everyone about our diversion pilot today, but she wasn't able to make it, so you get me. I'll do my best to live up to what she would have done, but I really think things have been covered pretty well. There's not a lot that I can add, with the exception of a few pieces and maybe a few examples. So I think when Elena was presenting the survey data and we were talking about the frequency of delusion, or the presentation involving delusion. So really, callers that might be more regular, known, familiar callers that have delusions around things that they are seeking a law enforcement response for, and so they feel like 911 is the appropriate place to be. And so tying that back to conversations around training, how can we give our staff and staff at 911 more support and training around how we might be able to better approach those individuals and those situations to have more productive outcomes. I think that's one example of several. I will say that we've seen in ebbs and flows during this short time of the pilot as well. I think we on both sides are maybe operating under certain assumptions, and that's changed over time. I think really looking back to the beginning of the meeting, when the panel was presenting and the discussion around staff consistency and workforce. I mean, I know particularly for our pilot that has been a challenge at different times. Really looking at having a specialized co-located staff that is different and involves a different level of training, intervention, and knowledge than maybe our broader group of crisis counselors. So I think just adding a little bit of that context, some of those examples, another place where I think we're making, and I want to make sure and highlight, we've learned a tremendous amount from the work that's been done so far. I think that's been really helpful. I think one thing where we'll, and this was kind of mentioned before on the work with technology and some of the other experiences, I think one area that we can focus on still is data, consistency and what that looks like. And we still have work between the systems on common language around some of the system pieces, intervention pieces, and data pieces. So really making sure that when we're talking about a specific piece of data that we're looking at or outcomes we're looking for, I think Diane mentioned disposition codes. So really dialing those things in so that we get more consistent. That will help with just the clarity on calls going back and forth, and then getting a truer and better idea about data and what things look like. So like I mentioned, lots to learn, still lots to learn. I think it's exciting, that we're kind of at this point, we're moving forward. There's some other pieces coming into play that will help overall with the pilots. And, I think the different experiences of the 3 988 centers and their pilots, there's certainly a lot of commonality, but I think that's going to also give us a better picture of what will work at every PSAP across the state. And how do we how do we bring this out to, kind of a larger systems level, and recognizing too that this work will take time. It's not something that we'll have perfected or streamlined, by January. It will take more time than that. And I think, I think having patience, and sometimes I'm saying that as much for myself as anyone else, that these pieces and this work does take time to kind of move through and get it to where we would like it to be. And I think I will just kind of wrap up and leave it at that. But, just again, highlight that it was interesting seeing the midpoint survey data, and I think lots of positive takeaways.
Yeah, thank you for that, Levi, and a great point around, the data that we get, even across centers, it's difficult to come to decisions around how do we, what is a diverted call? Those were specific definitions that we had to come to as a group, and could differ depending on how you cut the pie. But last but not least, I want to welcome Adam Wasserman, who's been a wonderful support to this work and really helped us get this work going. He's the State 911 Coordinator.
Thanks a lot, Elena. Yes, so from the 911 perspective, it's a great pilot project. We're learning a ton, and Diane, Sarah, and Levi pretty much eclipsed the high marks there of what we're learning. We're learning the same things on the 911 side. I will say that the 211 embed in the Valleycom Crisis Connection one is key, because 211 is a critical aspect. We use it a lot in 911 to get people to get people to resources that they can actually get them to, especially for some of those crisis levels that aren't quite reaching that crisis level. And I know crisis is in the eye of the beholder, so defining crisis is always a challenge. So I think it's critical to have 211. I think 211 needs to be more a part of this, and that's why we're really happy that Crisis Connection kind of wears those dual hats. The interoperability is going to be really critical, the interoperability of systems, because, as we say, we have some PSAPs that are getting just a handful of 911 calls. They still get, frequent callers, and they still get callers that would be better served in the 988 system. But we're not going to have, it's not reasonable to have an actual 988 crisis counselor sitting in that PSAP. So for a lot of the PSAPs, we're going to need to be able to transfer those calls, and we're going to need that interoperability. So the technical solution has got to come as soon as possible, along with those procedures and protocols, which we're learning in the process here. And then, as I think Sarah said, the key thing is trust. And, as they're sitting side by side with the crisis, as the 911 telecommunicators are sitting side by side with the crisis counselors, they're learning to trust them. And as you know, in 911, the telecommunicators, just like I'm sure 988 crisis call counselors, they take ownership of that person on the other line. They take an ownership of them, and to just say, hey, this person's in a crisis that, is better served by 988. It's hard to let go of that person, because they want to be there to take care of that person. So building that trust is key, and how we take that trust that's being built by person-to-person connections in these on-site projects, how do we translate that to the PSAP that's not going to have a 988 counselor sitting with them? And so what I would really like to say is, especially as we're doing the training, how do I get those telecommunicators into a room with these crisis counselors to talk, so they can meet them and, say, okay, I know you, I know kind of what you do, I feel safer and more trusting to actually transfer those calls to you, because a bulk of the calls are going to be going into PSAPs that aren't going to have someone, a 988 crisis counselor there. So I really look forward to that. Again, we are, hand in hand, as I think Rep. Orwell said, this is a marriage here, 911, 988, and I would throw 211 in there. And so we've got to get this figured out, and I think we're doing a great job, and appreciate Elena and all the team that are working to get this going. So we're standing by to assist and be right there with y'all.
Thank you so much, Adam. I know, Jamie, I can pass it back to you for Q&A, and I think it might be helpful if each of our speakers stay on, just you might get some specific questions as well.
Good call, Elena. So actually, Chloe, if you could spotlight our presenters again, and then CRIS committee members, here's your opportunity. I've already gotten a few questions or comments in chat that I'll put out there for us to discuss. And then I know that there are some other questions that might be coming from our CRIS committee members. And time permitting, I have a question for the CRIS committee to ponder. So let's start with some of the ones I received in the chat. Dylan and I were messaging back and forth. Dylan Nishimoto and I were messaging back and forth about the 988 transfers to 911 and in particular, the warm handoff protocols that I understand are going to be developed. Dylan was curious, and others are curious, to hear about the development of that protocol and in particular, what joint training exercises will look like to avoid professional conflict. So can any of our folks on the screen here talk a little bit more about that process of developing those protocols?
Yeah, I see Adam unmuting. Do you want to go first, Adam?
Well, why don't you talk about the protocols and I'll talk about some of the challenges we're having with the 988 to 911 transfers.
Yeah, that's what I was trying to figure out. Jamie, did you mean 988 to 911 or the 911 to 988 / other crisis?
That's a great question. I'm going to see if Dylan can jump in here and clarify what his interest is.
My first thought was actually 988 to 911, and I'm actually not sure what the numbers from 911 to 988 look like, because I don't think that was shared, but I'm guessing the volume from 988 to 911 is greater than the other way around. But that would just be a guess.
Yeah, great question. The numbers shared were those transferred from 911 to 988. But I'll leave it with Adam to speak on the other direction, the 988 to 911. I know he was here for the early mapping, and I think that each of our centers could also speak to, the responses or the number that they're seeing. I think the national average is 2% of all calls right now going to 911 in the case of someone requesting it for personal or potential harm. So I'll pass it up to Adam for now.
Yeah, I think, and that's one of the real challenging one, and it all comes down to the 988 counselor being able to locate the person through their discussion with them, especially if they're going to need emergency services. So that's a huge challenge. But 988 call counselors and the suicide hotline call counselors before 988 become a number are excellent at that. And I know they're trained very well and practice that very well. But there are times when they just can't get it out of them. Either the person doesn't want to give up, but you have to get an ambulance or a police officer or a firefighter there. So that's always going to be a challenge until we get some of the locations figured out. But that's where the protocols come in so keenly, because even though it is only 2% of those calls, if they're trying to get over to 911, those 2% are they're all life and death calls, I would say. But these are I don't even know how you would put it, the imminent life and death. So that's what makes it a challenge, and we're here to work with everyone on that. So.
For Levi and Diane and Sarah, I don't know if I'm sure you can't just pull the data up right now, but does that 2% number about resonate with you, and how does the process for imminent risk and that decision-making process work for your centers, for your counselors?
Yeah, I can actually speak to that. That was some of the data that we had pulled for this conversation, and our diversion data is looking very consistent with our general call team. So 98% of our calls are being de-escalated and navigated on the phone with our 988 team, and even within house with the diversion team, some do get transitioned back to 911. But our process is to stay on the phone with the caller until help arrives, until someone arrives. So we do try to our best to maintain support with them, but also to Adam's point, in some cases, someone is non-responsive or not engaging, and we know that we need to dispatch that emergency response as quickly as possible. But in the cases where we can, we'll stay on the phone with them so that they know someone is there until we have confirmation that an emergency responder has arrived. But yeah, those numbers are very consistent across the board so far.
Yeah, I would echo exactly what Diane's saying, which makes me have this moment of validation where I'm like, wow, our call centers are following these similar practices to become best practices. I don't have our data right in front of me, but our need for what we consider an active rescue and imminent response, like Adam mentioned before, are incredibly low. particularly with the diversion program. We don't often have a call that is transferred to us that then escalates to the point of needing an emergency response. It's not outside of the realm of possibility, but it is a lot lower.
And I don't know that I can add a lot. Very consistent with what both Sarah and Diane have said. I will say just historically, and I don't have recent data in front of me. Historically, looking at the numbers, we've seen it really remain in that 2 to 3% range. We have something that we've noticed in the past, and the data is a little bit of fluctuation on the rate of emergency intervention, active rescue, in imminent situations, a little bit of variation between the modalities. So maybe it looks a little bit different on chat and text than it does through phone. But we're really, we're talking about maybe 1% or less than 1% differences, but just, just some slight variation. And again, really historically that always being, in a range that's less than 3%. And often around that 2% or less range. So,
Lena, I think you're going to speak to Puck's comment that I just posted, and then I see a hand up from Dylan after that.
Yeah, sure. So what Puck said in the chat is that they understand from cross-systems collaboration systems meeting. So we're currently using the cross-systems collaboration subcommittee as an advisory committee, and so that's what Puck is referencing there. But Puck says that calls are not going to 988, and when they ask someone why, someone explained that so the handoff had local resources. And so to explain that, really currently in the tech platform that is run by Vibrant, the national administrator, there is no way to develop a backdoor number or a way for our 911 staff to call their local 988 center and skip the IVR, that recording up front that allows you to pick from those top 4 options. And we felt that would be inappropriate for a 911 response to have them sit through a recording and then be put on hold, be put into the statewide queue, and then be picked up either by the 988 provider in their jurisdiction that they're hoping to reach, or outside of it. So those concerns made us lean towards having basically backdoor lines or conference lines that would allow 911 to directly reach these 988 centers that they're intending to. We actually are exploring a technological solution to that with Vibrant. Currently, they're exploring a way to create those internally, but that doesn't mean they're not going to 988. These are 988 staff. They're operated by our 988 centers, and they're funded through our 988 line fund. So I just want to make sure I clarify this is being supported through 988, but yes, the numbers and the routing are what's missing. It's not going to appear on our broad state metrics, but we're really hoping to fix that, hopefully with the help of Vibrant.
Thank you for that clarification, Elena. Dylan.
Hi, thank you, everyone. One of the questions that came up for me, for Adam, you mentioned that the training that all the folks are highly trained on being able to help identify where someone's located. It's been 4 years since I took any of the telehealth trainings that were required by the state, but I'm curious if there are any current trainings that other providers could also take, because it is a challenge to identify if someone doesn't just voluntarily tell you where they're at. So if there is any additional training resources that we could maybe look to.
Yeah, that's a good question. I guess I was referring to the training they go through. From what I've seen with the 988 crisis counselors, they're very good at pulling it out of someone. By directed questioning to try to get a location on them when they're in need of help or they don't know where they are. If they're having hallucinations and they've driven off, they may end up in an area where they don't know where they are. And unfortunately, the way the system's set up now, there's no location on that if there is a need for that. So I believe there, but I will go back and talk to some of our telecommunicator training staff and see if they have. I'm sure within the T1, T2 training we give to our telecommunicators, there's also directed questioning training on similar things like that. So I will talk to them and see, and then I would love to see some combined training between the two systems.
And can I speak to that from the 988 side? To Adam's point, our teams, I know our clinicians are very well versed in coaching our call staff to get that information. And I can think of an instance specifically that turned into, I was listening and on the call myself and supervising and providing some support to the clinical team for an out of state call in Colorado. And the person was, you know, not very responsive on the phone and was slurring and was having a difficult time, but we were able to get them have them just find a piece of mail in their home and read us the address on the mail, and able to identify from that where we thought that location was and communicate that to the PSAP in the state they were calling from. And sure enough, they were able to actually show up at that door and find that person. And so the clinicians themselves and the call specialists are really able to ask them exactly that. What are any physical cues around you that can help us identify this if you're not sure? And we take every ounce of information that we can provide to get that until we ideally get better identification resources available to us.
It's good problem solving. Bipasha.
Hello, everyone. I just wanted to say I've been answering calls at a regional crisis line for decades. And I've heard a lot of competitive aspects between the regional crisis lines before, mainly fed by the lack of funding, nothing personal between these lines. But now to hear how these 3 988 centers are working together to align makes me really happy. I mean, it really does. It sort of embodies the no wrong door policy for the community. Like, regardless of who you get, you're going to get very consistent and high quality care, which is huge for the lived experience community. And in time, I hope that also happens with 911 and 988, that they both become just a doorway to enter the system and get the help. So big kudos to DOH, Crisis Connections, Volunteers of America, and Frontier Behavioral Health. Really kudos.
And Bipasha, I should have mentioned that in that marriage, it's not just 988, 911, 211. I include the regional crisis lines and all those other areas in there as well. It's a big marriage.
I also think it's important to throw that shout out right back at Bipasha and her group. The Lived Experience Subcommittee has been an incredible place for us to hear and not assume, and to make modifications and to endorse our training and to really, really make the rubber meet the road, where people are saying, here is what I need, here is what I need, here is what I need. Here's how it impacts me, here's how it impacts my family or my loved ones. And I've been fortunate to be able to participate as sort of a fly on the wall in some of those subcommittee meetings, and then take that information back and make some adjustments to the way we do things. And just a shout out back to you and your crew. We appreciate you.
I think that brings us to the end of the time we had for discussion on this topic. So I just want to give a big thank you to Adam, Levi, Sarah, Diane, and especially Elena. Great presentation, great information you shared with us. This has been top of mind for many of our CRIS members. And so we very much appreciate your time today. And with that, I'm going to ask Chloe to pop the slides back up and bring us maybe to slide number 51, please. Just have a couple of closing things. Excellent. So Elena showed these dates earlier on their slide. I'd like to just remind you of these dates. These are the community and tribal listening sessions on the 911 988 worm transfer protocols. And these are in the slide deck. That's on the dates are also up on the CRIS Committee website. You can take a screenshot right now if you like, but this is what's coming up. Just want to keep you posted on that. Chloe, did we have any? I don't think we had any other action items coming out of today, right? Did you take any?
Yeah, not that I can see right now, but we'll definitely follow up and take a look.
Okay, excellent. I think, and Christine, no public comments?
No public comments.
Okay. We have 6 minutes left. Any community members, last call? You could raise your hand right now. I could maybe take one public comment. All right, well then I'm going to give everyone 6 minutes, 5.5 minutes back in your day. Everyone, CRIS Committee members, thank you. This is our 24th meeting. You have done put in a tremendous effort into this. I think one of the joyful things coming out of today is hearing about and seeing some of the pieces that are starting to come together. That's pretty exciting. Still so much work for us ahead, but good to see these pieces coming together. A reminder, there will not be a big CRIS Committee meeting in August. Instead, we'll be doing smaller meetings to have discussions about the stories coming out of the Lived Experience Stories Project. And then we'll be getting together in person in September. So also just a big thank you to our ASL interpreters who kept up with the rapid conversation today. And finally, a huge expression of appreciation to all of our presenters and especially our community members who give up so much of their time to be part of this process. Thank you all. Have a good evening. Be safe. Enjoy the sunshine, and we'll see you soon. Take care, everybody.
Jamie, just a quick note to say before logging off.
Yep, I got it. All right. People dropped off.